Good afternoon, everybody. And today actually is a very special day for all of us at the IBD Emerging Nations Consortium. If you remember, we had a lot of discussions, lot of meetings, and it took us a long 8 months actually to get something we wanted, a registry on advanced therapies in this part of the world, the IBDENC BIOS, that is for biologics and small molecules. And finally, today is the day of the launch. And it is my honor and pleasure, and we have Dr. Nageshwar Reddy here. Sir is going to do the honors and tell us how to take things forward.
Good evening, good morning, and good afternoon, whichever part of the world you're in. I think, first of all, I'd like to congratulate ENC and Rupa for this initiative. I think what happens is whenever new molecules are introduced in developing part or emerging part of the world, they are introduced very randomly without a proper registry and follow-ups and so on. And what happens again is that we have seen this even with technology like recent spiral endoscopy, that something is launched, it goes into practice, it goes into the market, and then after several years, months sometimes, you come across either certain side effects or certain trends which would have been better if there's a registry that would have actually prevented these types of trends from coming in. So I think this is a very important initiative that Rupa and the ENC is launching, to start a registry to track what's happening, because we are sure that when these molecules are going to be used, we want to know what is the practice of their use, how to start them, when to stop them, and so on. So this is an important day where the launch is occurring. I think look at the need for such a registry, we also realize that the incidence of IBD is rising exponentially, of course, and also the use of biologics and small molecules. In fact, the small molecules, I think we have the cost coming down quite reasonably. They're being increasingly used in our country. And even in spite of the fact that they're much less costly than conventional treatments, you'll find that their use is still limited to a certain extent in economies which are not very rich. We have limited data to understand the real world efficacy and safety of these drugs in this part of the world, and therefore I think there's an important need to have this type of registry. This registry is going to be web-based, as most registries are nowadays. It's going to be a password protected, secured, advanced data encryptation, and of course user-friendly for every IBD with its own personalized registry. And this is what I want to emphasize again. This is going to be safe in the sense that every physician is going to have his own personalized entry into the registry, so that others don't know what's happening. But then, of course, you can analyze as a group everything that has happened here. There are huge possibilities and potentials what can happen in future with this. First of all, I think the most important thing is with the use of this registry, we are going to have a collaborative research going to be much easier. And I think in the IBD, and especially with the introduction of these new types of molecules, there's increasing need for this type of collaborative work in this part of the country. So I think this is going to become very useful. We can therefore define our own strategies, these emerging nations for advanced therapies. We'll know when to start, when to stop, when to restart, when to switch. And I think large number of these studies which are going to be very important, which potentially are done in the Western world, but not like what they're done in this part of the world. They're going to become very important and possible. So I think this is something that we look forward to. I'm sure this registry will become an important part of practice of IBD in the emerging nations. And I'm glad that the leaders that are joining us, not only from our country, but of course we see Simon and also adding to this, I think the wisdom that's going to come. As we go along, we're going to hear some of the talks now, and of course the panel discussion that's going to follow.
Dr. Reddy, the sound doesn't come through, at least on my end.
Can you hear me now?
Yes, now
Yeah.
it's great. Thank you.
So yeah, so the deed is done anyway. So we have unlocked the registry and started the first patient, and this would be, of course, be available for all the ENC members. Okay. So thank you very much for being here with us, and we'll continue now with the talks and the panel discussion.
Thank you, sir. As I said, it's a big event for us, a big day for us at IBD Emerging Nations Consortium. And to take things forward, can I have the slides, please? Can I have the slides? I think we are managing 3 points for the registry and this. So, can you see the slides? Yes. So now we are 25 plus countries, 2000 plus members. And this is a registry for us, a personalized registry for everyone. And you keep your data, there's data privacy, but when we decide, we get together on a structured way, we collect the data. To take things forward on such a great day, we have 2 keynote lectures by 2 very special people. Professor Simon Travis, who is the Professor of Gastroenterology at the Newfield Department of Medicine, University of Oxford, and Dr. Florence Solaro, who is the Director of the IBD Center at the Johns Hopkins University, US. This is followed by a very interesting panel discussion on the use of biologics, how this registry will help, which biologic when to start, when to stop, and with the moderators, Dr. G.N. Ramesh from Aster Medicity, Kochi, Senior Consultant, Dr. Ajay Kumar, who's the Chairman of the PanMax and Head of the Department of Gastroenterology at the Max Super Specialty Hospital, Delhi. We have expert panelists who actually need no introduction. Professor Ajit Sood, he's a professor, head of department, Dayanand Medical College and Hospital, Ludhiana. Dr. Usha Datta, professor and head, Department of Gastroenterology, PGI Chandigarh. Dr. Ida Hilmi, consultant gastroenterologist, University of Malaya Medical Center, Malaysia. Dr. Matthew Phillip, head of Department of Gastroenterology, Lissi Hospital, Kochi. And Dr. Mahmood Omar, consultant, senior consultant gastroenterologist at the New Mowassat Hospital, Kuwait. So we are looking forward to an interesting, great session ahead. And the first speaker, and before I mention, Dr. Simon is actually the mentor, guide, and support for IBD Emerging Nations Consortium. Whatever we are today, Simon, thanks, and an official very big thank you to you. Over to Simon for the first talk on the pros and cons and challenges of having a registry.
Rupa, you are too kind, and what a privilege and a pleasure it is to be presenting on this exciting day. And it's not me who's been doing the work, Rupa, it's you and every person in every country which makes up IBD ENC. And I should thank you for the title, which is the Logistics, Benefits and Challenges of Maintaining an Advanced Therapy Database. I've added my own comment that this is a purely personal perspective, because I have in the UK and elsewhere been involved in trying to establish databases over a long period of time. So congratulations, IBDENC and AIG, because it's a brilliant idea from IBDENC. It's ambitiously simple: to collect data on advanced therapies from over 25 different countries with a uniform method of data collection, which will allow real-world experience from countries with difficult access to advanced therapies and, yes, higher risks of infection. The information acquired is bound to be different from the West. It's bound to attract attention of clinicians, industry, and funders worldwide. So go for it. I'm really delighted to be celebrating the launch. But, and there's a big but, there's a litany of and less successful initiatives, and I'll just name some. They're not comprehensive. There was 25 years ago the Ferring IBD database in the UK. Then there was the ECHO's first database in 2007 called IBDIS, which was embraced by Kingdom of Saudi Arabia, but a few other locations. The IBD Registry, as much talked about, was established 10 years ago. And then ECHO has a current database called Your Care, and there are many, many more. But all suffer from one principal problem, and that is the lack of longitudinal data collection. What that means is that a database becomes little more than a address book of your patients without any outcomes or longitudinal data. And the reason for that is common to all of them. They require double data entry, and double data entry is daft. So if you're building a database, one that is standalone, that is additional to daily work, it just won't be used. The database must be integral to practice. And our most successful database is one that we've integrated with pharmacy prescribing. It has to be used because it's the database which in Oxford is used for accounting procedures. The other problem is complexity. All of us want real detailed information because it's never the primary objective, which is the most interesting. It's all the secondary objectives which you want to drill down and understand information about your practice. But keep data entry simple. By way of example of how not to do it, the UK IBD Registry takes 45 minutes of data entry per case. My goodness gracious me. No wonder people use it, register the patient, and don't go back and re-register or keep up longitudinal data. The other aspect, which I've learned from our mathematicians and software engineers, is that you have to ensure data timestamps, because this is what is needed for data integration. That may seem obvious, but when we started integrating our pharmacy advanced medicines database with other database initiatives that we've got in Oxford, I suddenly realized that data timestamps weren't mandatory. They were there most of the time, but not every time that a drug was started or even stopped. And that may seem remarkable, but it comes down to human error and human application. I'm glad that Dr. Nagy has commented on security, because that is a fundamental importance, and confidentiality. In the UK and Europe, we have the General Data Protection Regulation, and that will come in some form or another to India and other countries. But essential to the core of BIOS is the concept of data ownership, so that everyone owns their own data. So in other words, for those anoraks who are aware of such things, AIG is merely a data processor, not a data owner. But there is an agreement between each individual who contributing to aggregate de-identified data, and that's the power of the system. And that's what Rupa and colleagues are proposing and have launched today. So let me give you some examples from Oxford, because I said this was a personal perspective. We have one database for all of our patients with IBD. It's based on a platform called InfoFlex. It's versatile. We've got over 5,000 patients registered, and they all have generic research consent. But it depends on keeping up to date with an extensive research team specifically for this. It also suffers the weakness of having a commercial provider, which is not only expensive, but that single provider provides some vulnerability. There are commercial systems which are more widely used, such as RedCap and other systems, and I believe that the sustainability of a database depends on that sort of resilience, because the move of just one or two key personnel can jeopardize the whole, and I speak from bitter experience. So we also have the pharmacy advanced therapy database that I touched on, and I'll show you some data that has been acquired from that in a moment. It's integral to prescribing, so all advanced therapies, and we've integrated it with our real-time patient-reported outcomes, patient input system, the True Colors, where patients input their own data using validated indices. And that allows this concept of multi-parametric analysis, drawing in data from different databases, which have the common concept of a data timestamp. And well done, AIG, because in Oxford, we've done all this with zero IT support from the hospital at all. It's all through research collaboration with our software specialists in the university. So let me present some data from our database. This will be presenting at ECHO in 3 or 4 weeks' time, because we've been able to look back over our prescribing of anti-TNF therapy over the past 20-odd years. And we've used the pharmacy database and patient records, and our primary outcome was loss of response at any time point, and secondary loss of response after initial clinical response. What's interesting is the duration of time, because the overall people who kept on using infliximab at 12 months was 82% in Crohn's disease and ulcerative colitis. And at 3 years, it was down to about 2/3 to 3/4 in both conditions. Now, look at what happened to those started on adalimumab. That was 89% sustainability, so the large majority of people kept on going with Crohn's disease for 12 months, but only 59% of patients kept with adalimumab for 12 months with ulcerative colitis. And at 3 years, the difference is even more stark. And let me show you two Kaplan-Meier plots. The first using infliximab, and you can see there's very little difference between the two conditions, Crohn's disease and ulcerative colitis. But look at this for adalimumab, and being able to track our patients through and see that there is a rapid loss of sustainability in patients treated with adalimumab for ulcerative colitis compared to Crohn's disease has informed our future choice. That's just one example. And of course, the patient populations are different because we use infliximab for rescue therapy for acute severe colitis rather than adalimumab. But nevertheless, there is a very striking difference. And another approach that we've used are a bit like following the tail lights in traffic in Hyderabad. And that is following the pattern of the tracking the pattern of treatment across individuals. And it's called a Sankey graph, and it looks all over the place. People start with one, move on to another, or a different one, and move on to another. And this is just a very small study that we're doing, but it's down to single cell analysis. But I thought it just illustrated the point that if in your advanced therapy database, you're tracking what people start with, and then what they change to, and then what they subsequently change to, you can rapidly develop a picture of what is happening in an individual institution, which is of interest to you as the individual putting in the data, and then throughout the region, which is of interest to everyone. Just to give you another Sankey graph. This was by Corey Siegel, looking at a claims database in the States, and this is what happens in America. It's real world data. It's America, but still the real world. And you can see the huge proportion of people on ulcerative colitis, 5-ASA and steroids. And at this time, and it was some years back now, really a very small proportion on advanced therapies. And I think that when you're collecting data, you ought to focus on advanced therapies. And more than just patients on advanced therapies, I would advise you start with the new starters of therapy, because they rapidly build up and all the data are then prospective. If you just enter everybody who's on an advanced therapy whenever they started, first of all, it's difficult to identify the date timestamp. And secondly, they're really difficult to analyze. So those patients who are already on an advanced therapy are best added, to my mind, when they're switching to a newer agent, because then they become a new starter. But then, of course, you need to record what they've been on beforehand. But the most important message is work hard to ensure longitudinal data entry. Then you collect the data, the duration. You can collect the outcomes, and the outcomes of interest are infection, hospitalization, perhaps surgery, but really keep it very, very simple with outcomes that matter at a macro level across the region. And remember that less is more. Do ensure that past therapies are retained, because that informs the interpretation of the outcomes. And then you can enter a separate code for pseudonymization, which is kept separate to the database, so patients can be tracked and details accessed. But if you try and enter all the data on all the patients all at once, it's a massive undertaking. So if you want to keep this sustainable, my advice is start with the new starters or the switches, and then allow it to build up. and make sure that you go back to use this web-based system. And I absolutely applaud IBDENC because records are everything. Even when this slide was produced, then India had beaten England just the same number of times England had beaten India in the World Cup. Sadly, it's not up to date. And we all know that India beat England in the last World Cup. Congratulations there. Congratulations to Rupa. Congratulations to Nagy. It's a great privilege to be part of this. Thank you very much indeed. I'll stop sharing my screen. Thank you.
Thank you. Simon, brilliant. Thank you. And I think the first thing that I would like to say is that I am happy that here we have actually covered most of the points that you have highlighted. And to make things simple, when the patient is coming for follow-up, the data goes directly to the follow-up form in which just it will take 30 seconds to just say whether there is a relapse or there is no relapse. So things have been simplified to a huge extent, and then follow-ups like that, but the final Excel spreadsheet is going to be the same all across. And it will be, yes. So that is what we are planning. And I think I'd also take this opportunity to tell everyone, we are organizing training sessions for senior consultants as well as the person or your fellow who's going to do the data entry. So we will have one-on-one meetings for them, but it's just not, it's very simple and anyone can just log in and have a look.
Rupa, can I just chip in there? It occurs to me that if advanced therapies are prescribed from hospitals routinely, which I dare say they are, then involving the pharmacists is a good idea, because it's the pharmacists who are used to, much better than doctors, keeping track of what treatments are used. So just bear that in mind, that the pharmacists the hospital pharmacists may well be a key part of the team.
I think in many parts of the world, I mean, here, many countries will not have an experienced pharmacist. So we would leave the decision to the main consultant and he can decide who is best suited. But that's a wonderful suggestion. The only thing I just wanted a single question, because we'll have a lot of discussion at the end, of course, with you there as well. The only question I wanted to ask you was, do you think that in this part of the world, we really need different algorithms for treatment rather than what the Western world says?
Yeah. Oh, I would completely concur with you there, Rupa. For instance, if you're looking at an advanced therapy which changes the course of ulcerative colitis, I would be focusing on small molecules, tofacitinib in particular, and others when they come through. So they are different algorithms. But this is the sort of initiative which will inform about current practice, and then it will be possible to gather those data to inform on the treatment strategies and the sequence which appear best to suit the region. And it will differ between the ENC countries, of course, because some are struggling to provide healthcare at any level, and I'm thinking of one end of the spectrum there amongst the ENC countries, and others are actually wealthy economies, as we showed in that cross-sectional survey. So I do think there are differences there, and we've got to recognise that, and it means working together to try and develop the algorithms appropriate for the region in which people are working.
So thank you. And as questions start coming in, as I said, we'll take the questions at the end. We go on immediately to our next keynote address. And this is far away from biologics and advanced therapies. So it's an honor that Florin was free and able to join today for this occasion. But from you, we will learn, Florin, what about the future? What are the newer and exciting prospects? So we have his presentation here, which we will play, and Florin is there to take questions at the end of his talk.
Thank you, Rupa, for the invitation and to participate in the launch of your consortium. I think this is a wonderful, wonderful idea. More than happy to support with anything that the team can. As you mentioned, my presentation, as requested, looks more into the future. I think that a consortium vital step towards that future. Thank you, Rupa. Hello. Thank you for allowing me to speak at your symposium. Thank you, Dr. Reddy, and thank you, Dr. Banerjee, for the very gracious invitation. It is my pleasure to be here with you today. I'm Florin Celeru. I'm the director of the Inflammatory Bowel Disease Center at Johns Hopkins University. And I'm an IBD specialist as well as a scientist. I was asked to speak today about newer directions in inflammatory bowel disease, what's in the pipeline, and what we think it's coming. Obviously, this is a very controversial topic since people have various opinions about what's coming and what's next. I will show you a couple of the ideas and thoughts that I have in regards to some of the important areas in IBD management. Allow me to share my screen. Okay. So, as you all know, the past 20 years have witnessed a tremendous development of anti-inflammatory biologics. These medications have undoubtedly changed the lives of millions of patients with inflammatory bowel disease. More recently, small molecules have also been brought to the market. And importantly, we see patient populations that tend to respond better to small molecules than to biologics. So certainly, these molecules have a place in the management of patients with inflammatory bowel disease. What is next? As I mentioned, this is a topic where there are many opinions. I will show you what I think is important and what I think that the next few years will bring. I think that it's very important to have a better understanding of patient strata that would allow us to personalize our treatments. And patient registry efforts, such as the one that Dr. Banerjee is pioneering, will allow understanding of such patient stratification that by extension would allow better treatments. I also believe that treatments of complications from inflammatory bowel disease will start to come into their own right with more precise and better treatments for such treatments. For example, I believe that fibrostenotic complications require special care as well as penetrating complications such as fistulas. Last but not least, I believe that collaborative approaches where clinicians, scientists, and engineers coming together are very important. The focus of my presentation today will be on such collaborative approaches, and I will highlight a couple of examples from our experience at Johns Hopkins, where clinicians, scientists, and engineers come together to design and devise new management strategies for fibrostenotic complications and for fistulas. These are a couple of fairly recent pictures. What you have on the left is the Johns Hopkins IBD Center, composed primarily of clinicians as well as scientists and supporting staff. And on the right is one of the collaborating groups of my group, which is the Center for Nanomedicine. And the reason I show this picture is to highlight the close collaboration between our two groups. What I will tell you about today are strictures in Crohn's and perineal fistulas in Crohn's, but in parallel, I will tell you about nanocrystals as a delivery method for strictures in Crohn's, as well as nanogels and nanofibers for perineal fistulas in Crohn's. On the left is a representative image of strictures. On the right, you have the nanocrystals that we have developed to treat such strictures. And what you have on the left, on the lower part of the slide, is a representation of perineal fistulas. And on the right, you have a representation of a gel infused with stem cells that we have designed to treat such perineal fistulas. This is an acknowledgement slide. I am deeply grateful to the Crohn's and Colitis Foundation, to the Helmsley Charitable Trust, as well as to the National Institute of Health for their generous support of my laboratory and our research endeavors. For your reference, the paper we published last year in Gastroenterology, and it tells the story of how we developed an injectable drug-eluting nanocrystal formulation to prevent fibrosis and stricture formation. The reason we focused in strictures is because of these data in large part. So this is an earlier study that shows that at approximately 10 years after diagnosis, 50% or so of patients with Crohn's disease have undergone surgery. And the reason for the surgery is mostly fibrostenotic complications, but also for perineal fistulas. So patients with Crohn's and patients with inflammatory bowel disease in general at large numbers and in large proportions undergo these complications. As you know, and I mentioned earlier, there have been a number of potent anti-inflammatory drugs, biologics, and small molecules. However, unfortunately, there has been no population-level decline in the rates of obstructions or surgeries. And after surgery, strictures almost invariably recur, resulting in further dilation of surgery and loss of bowel. So what's needed? Well, we would like to have a small molecule or a medication that is effective as an antifibrotic. We would like to have something that can be delivered locally, since anastomotic strictures in Crohn's are local conditions, and preferably we want to apply the drug locally without exposing the systemic circulation to the drug. We want a sustained release formulation because after we dilate the stricture endoscopically, the mechanisms of wound healing occur over the next few weeks. So therefore, we want the medication to also cover that period of time. Of course, we aim for safety. It's also great to have good tissue diffusion and, as I mentioned, zero systemic exposure if at all possible. We started our project by designing a high-throughput drug screening for effective antifibrotics. Without going into detail, these are some images from our high-throughput drug screening pipeline and how we found that a known and FDA-approved antifungal medication by the name of sulconazole appeared to be a very effective antifibrotic medication. This slide also shows further confirmatory tests that have shown that sulconazole decreases the activation of fibroblasts, decreases alpha-smooth muscle actin, and also it decreases the secretion of collagen. So therefore, it's an effective antifibrotic. In order to have a sustained release formulation of sulconazole that is given locally at the site of the anastomotic stricture, after the anastomotic stricture was dilated, we turned to our collaborators in engineering to help us design such a sustained release formulation. And sulconazole lends itself, because of its chemistry, to crystallization. In other words, we form nanocrystals, and this is a schematic of how we make the crystals from sulconazole. And these crystals are able to sustain the release of sulconazole over a period of weeks. In order to test our drug, we developed a series of animal models. What I wanted to show you today is the swine model that we have developed. The swine model is a model of short luminal strictures. We developed this model in the esophagi of pigs. The reason for the choice of the animal model is because of the similar size of the GI tract, so therefore we can utilize our own instruments that we use in our practice. We found that there are shared features of strictures in the esophagus to the small bowel and colon, so therefore we chose esophagus for the ease to develop the model. This is a piece of a gross specimen from an esophagus where we induced the stricture, and you see here the area of the stricture, and these are serial sections that demonstrate not only how the lumen of the esophagus is less and less, but also how the thickness of the wall, because of the fibrous component of the lesion, gets larger and larger. This is how we induced the model. At day 0, we used archoplasma coagulation to induce trauma and burn trauma that then at day 14 results in a very tight stricture. And that the same day when we characterized the stricture, we dilated with a balloon similar to how we dilate anastomotic strictures, and then we inject locally the sustained release formulation of sulcanosol. At the top here, you have 3 strictures that were dilated and that were not treated with sulcanosol, and we see that in 2 weeks the strictures recur and are very tight, similar to what happens in strictures that we dilate in our patients with Crohn's. And what we have at the bottom are 3 strictures that were dilated, but also that have undergone injection with sulcanosol nanocrystals locally for sustained release. And we can appreciate that the lumen of the stricture has been maintained, which is in sharp contrast to the above. In conclusion, I hope I have shown some data to demonstrate that the design and manufacturing of sustained release antifibrotics is possible, and also that they can prevent recurrence of intestinal strictures. And it is my hope that our research will bolster future endeavors that will eventually lead to clinical trials with antifibrotics for the local treatment of strictures in Crohn's. I would like to move on now to the second topic of my presentation today. I mentioned in the beginning that the second area where I believe that work is needed in patients with inflammatory bowel disease are perianal fistulas and penetrating disease. And this is a paper we published also last year in Science Advances that demonstrates the design of a nanofiber hydrogel composite that improves tissue repair in a model of Crohn's disease perianal fistulas. When we started the project, we asked what is needed to treat perianal fistulas, and we decided we wanted a nanogel nanofiber composite that can fill the defect. We wanted a product that mimics tissue stiffness. It cannot be too soft, otherwise the high mechanical forces in the area will push the gel out. We also don't want a stiff product that would act as a foreign body. Importantly, we wanted a gel that can retain stem cells in the plug. We know that stem cells are effective in inducing regeneration and healing in patients with perianal fistulas. We also know, however, that stem cells can migrate away from the fistula tracts and therefore lose their effectiveness. We would also like the ability to affix the product to the area of the fistula. We would like the fistula plug to allow patient cells to populate the plug and therefore participate in healing. We want to increase angiogenesis and also would like the plug to be immunomodulatory and decrease the inflammatory component around the plug. These are three gels that we have designed with different stiffness levels, and we can see that the size of the pores is increasingly smaller as the stiffness increases. I will not spend a lot of time on the technological side of the gels that we have designed. For those interested, please go ahead and take a look at our paper published last year. We have also shown that as the gel gets stiffer and stiffer from top to bottom, it tends to maintain its shape better. So this is a stiffer gel, this is a softer gel, and we see that the size, the shape of the gel is maintained over 28 days. The stiffer the gel is compared to the softer gel. We have also shown that these gels maintain and retain stem cells at the site of the fistulas, which is seen here for all three thicknesses of the gel. These are stem cells that are maintained to day 14. In contrast, stem cells that are injected on their own tend to migrate away from the site of injury. We established a Crohn's disease perianal fistula model in rats, and for details, please see our publication. Suffice it to say that we have reproduced in rats some of the salient features that we see in our patients with perianal fistulas, including the fact that there are perianal tracts and the intense inflammation in those tracts, as well as epithelialization of the tracts. These are the results from the utilization of our gel. Here at the top, we have a comparison between surgery alone, and you can see that by performing surgery alone, which is composed of the closure of the internal orifice of the fistula, does not result in closure of these perianal fistulas in this animal model, which is similar to our experience in patients. What we have here on the left is the gel alone that actually induced on its own some healing of the fistula. What we have here at the bottom is the gel plus the stem cells that in many of cases that we tested resulted in complete closure of the fistula tract. And the graphical representation of these results is here, where we see that the reconstructed fistula volume in cubic millimeters is the least in the arm with the gel plus the stem cells, compared to the gel alone and compared to fistula surgery alone. In conclusion, the composite that we have created that's loaded with adipose-derived stem cells promotes healing of fistulas compared to the other groups. Again, this was published in Science Advances last year. For those interested, I encourage you to go and look at our paper. In conclusion, we have made great progress with both of these directions, both with the anti-fibrotic as well as with the fistula gel. However, there are a number of steps that need to be taken to take these inventions to patients. These are some representative images for the nanocrystals as well as for the gel that we have created. In conclusion, I would like to thank again the funding bodies for our research, as well as Dr. Banerjee for the generous invitation to have me speak at your meeting. And also, I'd like to wish you success in your endeavors, and I know that you will actually have great success. So with that, I thank you and have a nice day.
Thank you, Florin. That was mind-boggling. And I think as the questions come in. I have two questions already. I think we have Dr. Rajendra Patel. He is a part of the IBD team at AIG. Raj, you wanted to ask a question.
Yes. So it was a wonderful talk. I have two questions. Like with the advancement of new small molecules and use of nanotechnology, will the use of biologicals come down or they will wean off? And the second question is whether we foresee any new drug, that is anti-fibrotic drug, that is oral or injectable, which prevents fibrosis when the Crohn's disease heals off.
Thank you for the question. These are hard questions. I don't know the answer really to the first question, if the small molecules will replace the biologics. What I do know is that I have a cohort of patients who are and have very much in remission, in deep remission on biologics. We don't do a great job at identifying patients who do well on any particular medication in a prospective fashion. We know that a cohort of patients end up in deep remission on biologics, and I see little reason to switch them to a different medication. So the level of evidence would be overwhelming for a small molecule to induce that, or other considerations such as economic considerations, the difference in cost, etc., which could very well be the case. Small molecules, as you know, are chemicals that are made at the price point, in particular once the patents expire, then can be more attractive than biologics. So I guess time will tell. I think that registries will give us more and more about how durable is the response to any of these biologic or small molecule classes, and also hopefully will allow us to better stratify our patients to which patients respond to which medications. In regards to your second question, the development of an antifibrotic, that's also a very tough question. I think there are two sides of fibrostenosing complications in Crohn's and also in ulcerative colitis. One of them is the initial process, which is very tough to address, in particular because when we find areas of narrowings, in particular in the small bowel, the process in my mind already occurred to a certain extent. So, and I'm not sure about reversibility. Then when you have anastomotic cold strictures, the processes tend to be somewhat different. There is more fibrosis and less thickening of the bowel wall. So I think we need to differentiate between the two of them. I find it very difficult to address, and I think we need to understand a lot more about the natural history of Crohn's and, again, patient stratification. The second one is probably, and as you know, that's one of the areas of my interest, and I think that when you have scar formation without much inflammation, it's to address, and we are developing a locally administered sustained release medication for anastomotic strictures. Thank you so much. These are great questions. Thank you.
I think anybody from the panels, I think Dr. Ajit Sood wanted to ask something. So from the panelists, any quick questions and comments as well? Dr. Sood.
You are muted, Dr. Sood.
Ajit, you're muted.
Yeah. Is nanocrystal technology safe in presence of ulcerated strictures? Because most of the Crohn's strictures are mixed inflammatory strictures. Very less often they are purely fibrotic strictures. Do you think that presence of superficial ulcers will make a difference, or is it safe technology?
I think it will make a difference. The reason that is because the technology, as I'm thinking about it, and as we are designing it, will address collagen and fibroblast activation, which is a side that is currently not addressed by anti-inflammatory drugs. So I think that the strategy will address the side of the continuum of processes that exist, and that side is related to fibroblast activation and deposition of scar tissue formation. Safety is, I think, a question of how you tune the delivery method and the medication itself. At a certain level, yes, it will affect wound healing, and you have to be very about that. But certainly, wound healing processes tend to be abnormal in patients who develop excessive scar formation at the site of the anastomosis. So I think there is room to address those processes in a safe fashion. Thank you for the questions.
Simon?
Yes, thank you, Florin. Intriguing talk. My question was about the model that you're using, which is a model of traumatic or ischemic strictures and how that relates to inflammatory strictures. In some ways, it's a variation on Ajit Sood's question, because inflammatory strictures are surely pathogenetically different to ischemic or traumatic strictures. And perhaps your swine model is most relevant to the post-surgical anastomotic strictures of an ileocolic anastomose. And that's a useful thing. Don't underestimate that. But I wondered whether your perception or your perspective on inflammatory strictures in contrast to ischemic or traumatic strictures.
Yeah, that's a great question. So taking a step back, the biology of collagen deposition and fibrosis, quite a bit of experience from the liver side of things. And we know by looking at the basic science that has emerged from liver research over the years, that the pathway. So you can start with, I'm talking about liver now. If you start with alcohol injury, if you start with medication injury, if you start with inflammatory injuries such as primary sclerosing cholangitis and others, the end result tends to be the same. So I think that at some point there is a convergence in terms of fibroblast activation. I think that ultimately it's about fibroblast activation and hypersecretion of collagen that is a unifying theme in the fibrosis of liver. Now, there is also research that says that this same theme happens across organs. You can see the same mechanisms, for example, in heart fibrosis. You see the same mechanisms, fibrosis, idiopathic pulmonary fibrosis, skin fibrosis, etc. So I think there are shared mechanisms that have to do with fibroblast activation. Going back to your question and to inflammation in Crohn's, no, our treatments will do nothing to inflammation. They're not designed to address inflammation. They are designed to be an adjunct to anti-inflammatory of sorts, be it of the small molecule variety, be it of the biologic variety, something that would essentially limit the further and ongoing stimulus, inflammatory stimulus that results in fibroblast activation. So I very much doubt that the antifibrotic treatment developing or any antifibrotic treatment that focuses on fibroblast activation will actually affect the natural history of the disease in terms of the inflammatory side of things. It will be an adjunct in terms of the fibroblast, but only as an adjunct to anti-inflammatory medications. I hope this answers your question.
Yeah, no, that's right. It's just,
yeah.
Can you switch off the antifibrotic activity?
Yeah, so we can, and the way we do it, yeah, the way we do it is so about this is two parts. My mind tends to be pretty simplistic. So you have the part that is the small molecule that is the effective antifibrotic bit. That now small molecules tend to have a half-life measured in hours, right? Now wound healing tends to happen over days, weeks, etc. Right? So basically, component, which is the sustained release portion, because what we're developing, we're injecting locally after stricture dilation. So basically, we can tune the delivery, the effective component, and we do that through tuning the platform of delivery, which is, pharmacology. It's sustained release that have very little to do with what you actually deliver. So what you deliver is one side of things, and the way you deliver it in a sustained fashion is the second part of the equation. You can tune that, yes.
I think, Florin, you can guess that this was really a thought-provoking talk, and I'm sure there'll be a lot of questions coming in later as well. But I think now we switch on to the most important part of our discussion today. What about all the biologics and small molecules in this part of the world? And how do we proceed forward? For this, we have the panel discussion, and I would invite Dr. G.N. Ramesh and Dr. Ajay Kumar to take over and continue with the panel.
Thank you very much, Rupa, and thank you very much, IBDENC, for this opportunity. Dr. Ajay and myself are grateful to you for having given us this chance to put together this panel. The topic is Spectrum of Advanced IBD Therapies, Preferences and Selection, and Dr. Ajay and myself will take you through this panel. We have a very rich panel. Dr. Ajit Sood, who's almost like a legend as far as IBD is concerned. Dr. Usha Datta, a gastroenterologist with a lot of conviction, and she's got very firm ideas and opinions. Matthew Philip, my colleague from Kerala, who's got, to his credit, a lot of publications as well as rich experience. Mahmood Omar from Kuwait, we had the opportunity to meet earlier at Hyderabad. Wonderful, Mahmood. And I was looking at the crystal ball, and the crystal ball tells me that the fifth panelist, it's a very important day for her. And I was told that she's celebrating her birthday today. So, Ida, I welcome you with a very, very warm wish for a very happy birthday. Ida, you can correct me if I'm wrong.
Thank you so much.
So as
birthday,
so
happy birthday, Ida.
Birthday.
So I've
Thank
just
you.
noted down a very short, sweet message for you. As you blow out the candles today, may you cherish this special day surrounded by the love and appreciation from those who are lucky enough to call you a colleague and a friend. So happy birthday, dear Ida. And with this, we start
Thank
off.
you.
And thanks a lot for joining us on this special day, because maybe I would not have. I would have said that I'm more busy celebrating my birthday. So thanks a lot for having joined.
Okay, I can never say no to Rupa, and I can never say no to my IBD family in India. So glad to be here. Thank you for the wishes.
So we will take up this panel in five sections, and the first is Crohn's, and then we move on to ulcerative colitis, new possibilities and concerns, exit strategies with biologics, and maybe, if time permits, some dicey situations. And I have my colleague, Dr. Ajay, who is going to take up this first section on Crohn's disease. Ajay, over to you, and you can tell me when you want to change or go on to the next issue, and I will do it. Ajay.
Ramesh, can you start the first part of the discussion?
Okay.
I'm just about to reach my office.
Don't worry.
I'm in the vehicle.
So the topic, of course, is the use of biologics and small molecules
Professor
in.
Simon, are you there? I just wanted to Oh, yes. Oh, yes. Yes. Thank
Dr.
you.
Simon is here.
Yes.
So, Professor Simon, I shall take the liberty of picking on your brains as and when we come to certain issues. So that is always there. So we'll start off with the first issue, and that is what would be your first line choice of biologics? Maybe if I could start with Ajit Sood, because yeah, he had joined in early. Ajit, today in 2024, for a patient with fistulizing Crohn's or stricturing Crohn's, and then maybe you could take up the third segment also, non-fistulizing, non-stricturing Crohn's, what would be your first line choice of biologics if you were to use?
Thank you, Jian. I think today we have options as the treatment drugs have expanded, and we have among biologics, we have anti-TNF agents, anti-integrins, anti-interleukin P40 and P19 agents, and small molecules, selective JAKs, and we have sphingosine 1 phosphate receptor modulators also, and microRNA drugs are also coming. So we have number of drugs available, and that is what makes our treatment more challenging rather than solving the problem. Now, the fact that there are so many drugs are available proves the fact that there's no perfect drug available to us. And that is why this question becomes very, very relevant, that how to choose between the many drugs and how to position various drugs. And start with the Crohn's with inflammatory disease, that there's no single answer to this. But if we have to choose between the drugs, we have had the maximum experience of using anti-TNF agents, and now of late we have available UST with us, anti-P40, and so these are the two drugs. I'm going to say more what is available to us in India. So the choice becomes between anti-TNF agents, anti-integrins, and anti-interleukins. Now, this we can't have a generalized drug because that depends on the situation. Now, if a patient has moderate disease, UST is a good option because the safety profile is better, efficacy is good. On the other hand, if a patient has very severe disease and we want a rapid action, then anti-TNF agents, more so than infliximab, has a better application. And other situations where anti-TNF agents, infliximab has an edge over UST or BIOS, perianal fistulizing disease, or patients who have extraintestinal manifestations. Sorry, while
Okay.
UST, sorry, I just actually this is I think this is what I just want line one, that patients who are elderly or who have disease in the past, like tuberculosis or malignancy in the past, they're not very good candidates for anti-TNF agents, specifically infliximab. So we have to choose a drug. I mean, moderately severe disease, both are equal. The safety profile is better with UST, while for severe disease, perianal fistula, EIMs, infliximab is the preferred drug.
Okay, thank you, Ajit, for having brought in clarity. So I understand that the third category, probably you will just you would probably prefer UST. The first two, especially the first one, you would still go in with conventional infliximab because it's a more rapid acting and it carries with it the weight of evidence. What about stricturing Crohn's? Would it what would be your choice?
Yes, I mean, like in strictures, as we mentioned earlier, we discussed earlier, most of the strictures in Crohn's are not pure fibrotic. But pure fibrotic strictures, biologics are not going to make a big difference until unless we do dilatation or resect out. Or, I mean, if we're lucky enough to have something like nano and sucralfate or drugs like that, where we can combine with the biologics. Otherwise, patients who have inflammatory strictures, there it goes same way. I mean, if the disease is moderate, still UST or even BIDO can be considered.
Okay. I would now move across to Dr. Mahmood Omar. In your part of the world, Kuwait, are these the same choices that you would take, or would they be any different?
Sorry, said hello.
Yes, yes, yes.
Yeah. For the third one, I agree. I use ustekinumab to start with. For the fistulizing Crohn's is infliximab with ceton in place.
Okay, okay.
But for
So,
the non-stricture, non-fistulizing, usually I start with ustekinumab.
okay.
It's proved in many trials to be effective with either randomized trials or real-world trials. I think 1/3 of the patient remains in remission after 2 years. And there are some data about vedolizumab, but personally I start with ustekinumab.
Thank you, thank you. Dr. Matthew Philip, Ajit mentioned about stricturing Crohn's and the inflammatory component and the fibrotic component. How do we really assess whether it is a predominantly fibrotic stricture or inflammatory stricture? Is very difficult, isn't it? So do you necessarily go through a course of biologics or biologics before you decide that this patient is not really going to respond?
Ramesh, in structuring Crohn's disease, it is not the isolated stricture alone. The patient will be having disease other parts of the bowel as well. One is that, and we can have a look at the inflammatory markers on these patients. And I have seen that imaging will help you out with telling the probability of inflammatory component in the stricture. In those cases, I will definitely try with the biologics, and my choice may be depending upon many aspects, financial aspect, many aspects. But my commonest drug which I use is anti-TNF, and out of which is infliximab. But for small bowel Crohn's, especially with stricturing, I may try adalimumab. The reasons I am not sure, because there are some studies, there is at least one or two studies saying that probably this could be of some use in these patients. But my personal thing is that patients' financial situations, when comparing to other drugs, adalimumab is slightly, because of the biosimilars we get in India, it is slightly cheaper. Okay. But definitely I'll follow these patients and find out if their response is not that great. I will not continue. Go for procedures like endoscopic dilatation. I will start taking surgery like.
Yes, yes, because this is particularly in light, we'll come to that later, of a very recent article which said that surgery, many of these patients actually do very well with surgery upfront. Anyway, are all the other panelists in sync with this opinion, or do they have any other differences in opinion? Professor Simon, your comments on this.
Yeah, I just wanted to make two comments.
Yes.
The first, as far as fistulizing Crohn's disease, and Mahmoud Amar touched on this, and that is that it's unreasonable to expect medical treatment alone to treat fistulae. We're talking perianal fistulae there, and therefore it needs to be done in conjunction with effective drainage with a surgeon. And I think that's a really important thing for medical IBD specialists to remember, that medical treatment is an adjunct to effective drainage to stop abscesses occurring. The second is coming back to stricturing disease and the simple law of physics, and that is that flow through a cylinder is Poiseuille's theorem inversely proportional. The degree of obstruction is inversely proportional to the fourth power of the radius. What that means, you don't need to dilate it very much in order to make a material difference to the degree of obstruction.
Okay, thank you so much. We now move on. This second issue is, of course, we've really touched upon it, and Dr. Ajit was quite clear and crisp enough to tell us that for severe diseases, his choice would be infliximab because of rapid onset of action. For moderate disease, mild to moderate disease, where we are looking at biologics as an option, UST would be the option. So I think we'll skip this one. The third one is vedolizumab. Now, Okay. Now, I'd like to ask Dr. Usha Datta. Now, we've had a lot of information on vedolizumab, even though this is something that came up was first approved for ulcerative colitis, but there are now increasing number of reports of vedolizumab being useful in Crohn's. And do you think with the safety profile and the fact that it is now available in this part of the world, do you think it is a threat to other biologics?
Yeah, it's a very important question with now Vido being available in our country and also in the scenario of having tuberculosis around in our country. So vedolizumab has lesser systemic immunosuppression. It may still have some gut-related immunosuppression. So it is useful in our country where we expect increase in the incidence of tuberculosis in patients who are on biologics. So from that point of view, it is better. The second thing is we should also consider that patients where we can't make a definitive diagnosis of Crohn's and tuberculosis is still lurking, Vido will still have to be carefully used in that subset of patients because it could still flare up GI tuberculosis. But otherwise, Vido is a threat to the other biologics.
So I'm so glad that you brought up this point because still in 2024, there are situations where we are not really sure whether we've been able to rule out tuberculosis completely. So it would be important for us to consider that this as a viable option in this particular situation. Any comments from any of the panelists as far as Vido is concerned in Crohn's and any experience?
Yes, Ramesh, I might
I have a comment too.
even with the extension of the same question to Ajit. Ajit,
Yeah.
what is your when you stop choice of infliximab or UST? I mean, is it based on the literature or is it based on a personal experience? Especially coming in context with the use of Vido now, do you think you foresee any future changes in your approach in that? It's just an extension of the same question.
Yeah, thank you, Dr. Ajay. What I said is not my personal experience, it's what literature quotes that for moderately active disease, UST is a safer drug. Safety profile gives an edge over infliximab. And at the same time, if you say that if you have to choose the drugs for moderately active disease, UST and even Vido is a reasonable option, I would say. And I think when Dr. Jian says that this is the threat to other biologics, I think that's not the situation. It's a good add-on. It's a good drug which is available to us. And there is a literature which shows that the people who are on Vido for maintenance, they do better. Vido's only problem is that this takes longer time to act. So it's not very, very effective drug for induction. Its induction results may be little lower than the other drugs, but its maintenance is good. Like compared to infliximab, which is more immunogenic, the loss of response with infliximab is more likely to happen as compared to anti-antagonists like Vido or UST. So I will say that Vido is a very good option available to us. And it should be that if choice is between UST or Vido, and as a matter of fact, this is a very good second option for patients who don't respond to first line choice, UST. One can always try Vido. And I say again, because this is not a threat, because we can combine Vido with other drugs as well. Vido and anti-TNFs or even UST can be combined.
Ida, you wanted to make a point.
Yeah, I have to say that I don't use Vido very much for Crohn's disease. I think it definitely does work. There's absolutely no doubt. The Gemini studies have shown it, and I was part of it, and definitely there were people who responded very well to Vido. They've maintained on Vido. I guess the problem I find is that it is slow acting, and I don't know, Simon may disagree with me, and I'm sure he's going to say something. I find it a little bit more unpredictable. Ustekinumab, is it better than Vido? That's the controversial question that I would put, because I think some real world data suggests that it might be. Of course, there are no head-to-heads, and I guess it probably acts, in my opinion, a little bit faster. Is it as good as fast as infliximab? Again, it might feel that it isn't. So the problem now is when you're thinking about safety, is vedolizumab safer than ustekinumab? And I think if you look at the data from the psoriasis studies, there's really no evidence that ustekinumab is less safe than vedolizumab. Because I think if you look at the reactivation of tuberculosis, hepatitis B and all that, malignancy, you're not really seeing much of a signal. So it now comes down to if you're going to choose the two drugs, what would you choose, if the cost were the same? If the cost was different, then that would be a different thing altogether as first line. Coming back to vedolizumab as second line after ustekinumab, I don't know if there's any data for that at all. Vedolizumab has, of course, been looked at in, as a rescue therapy in the past, as second line following mainly anti-TNF failures. No, but I don't know what the data is after ustekinumab failure. I don't think it would work. That would be my opinion. And I think the problem is that now, again, if you put ustekinumab and vedolizumab as second line, what would still be the better option? Because in my opinion, I thought, again, that real-world data favors ustekinumab. But this is all notwithstanding the cost issue, because obviously the cheaper drug, would still be very much coming into play. Simon, you're going to say something.
Well, Ida, yes, and I'm gonna slightly disagree with you, in that I think vedolizumab is a great drug for inflammatory Crohn's disease, but can't be expected to have an effect in fistulating disease, and I would reserve it if there's stricturing disease. Then again, I would agree there are better drugs available. If you look at network meta-analysis, ustekinumab and vedo appear to be okay unless patients have lost response to or not responded to anti-TNF therapy. Second line, vedo, I think, takes second place to ustekinumab in those circumstances. But it is a good drug. I know its main primary role, as you suggest, is in ulcerative colitis, but for inflammatory disease, we've got quite extensive inflammatory disease without stricture. I think it has a good role. But Ajit, coming back to you, and everybody on the panel and elsewhere, for goodness sake, let's have the data on vedo and ITB. Because I suspect I would be worried about using vedo in interstitial TB. And we really do need those data, because at the moment, it's got an extremely good safety profile, which makes it very appealing in younger or older people. But the question where there's doubt about whether it's Crohn's or interstitial TB, I think the jury is out, and we'll only get that answer from IBD, E and C, and that's why I hope we have the data from the registry.
Thank you. I think that's a very relevant point. I think it was Usha who made this comment on the use of vedo in wherever there's some sort of we've not been able to rule out tuberculosis with any degree of conviction. So we move on. I think, yes, the jury is still out. Vedo versus UST. Some would say vedo holds great promise in Crohn's. People would still stick on to UST. But I think the jury is still out. Am I right? Or can we move on to the next issue?
I just have one quick question for the panelist.
I have one point here.
Yeah, just one point. Here I want to know, because vedo has slower onset of action, and in active Crohn's, can we use infliximab followed by vedo after you have
antibody? Usha, you'll just be creating antibodies to anti-TNF therapy, I think, that way. And hey, hang on Tuesday's a thigh prick. Do you remember that? For Crohn's disease, put your hands up. Okay, everybody has. And if you're talking about speed of onset, then what matters is sustainability. And I think there's no question that vedo has better sustainability than anti-TNF therapy, and that's one of a big asset. Yes, it takes a while. Yes, you may have to bridge with steroids or whatever, but I think sustainability and safety are major pluses in my book. But there's no perfect drug for treating Crohn's disease, that's for sure.
Dr. Ramesh, can I make a quick question?
Yeah, Rupa.
I just wanted to ask one thing, that if vedo is the more safe drug, and we know that whichever drug is given to anti-TNF naive patient it works the best. So can there be a strategy that for our part of the world where tuberculosis is so predominant, we start with VIDO, doesn't work, we switch to anti-TNFs? So because
this is something that the studies have shown that VIDO is best. The results of VIDO are best when it's used in naive patients and as the first choice. Am I right?
Yeah, absolutely. And we do that for ulcerative colitis, you know. I think we're talking about Crohn's disease, but it's a reasonable strategy, it seems to me. But just be cautious that yes, it takes a little bit longer to work, but if it works, then it's very sustainable.
But the point that was made by Usha was exactly the same point that struck me also. And why is it that we cannot induce a remission with a more rapid acting drug and then switch on to something that we think is slow acting but is safer? So that's something that, but I don't think we have any data to prove. Dr. Ajay, welcome back.
I think
yeah.
I could. Can I just talk about that? Because I think as Simon was saying, I mean, initially I've done that before. Actually, I have given infliximab to someone who then and then I gave vedolizumab. She was a medical student who's very paranoid about the side effects of infliximab. But in the end, actually, she didn't respond very well to vedo, and I had to switch her back on infliximab, and she's remained on that since. But I think the real question that was brought up by Simon is this antibodies, because if vedo doesn't work, then you then would have developed, by using infliximab in the first place or anti-TNFs, now you're going to predispose them to, anti-drug antibodies if you decide to switch. So I guess the question is, Simon, what about small molecules? Because I'd like to think that won't happen. So you could theoretically perhaps give a rapid-acting small molecule and vedolizumab at the same time. What do you think?
Oh, yeah. There are lots of people wanting to speak, but yes, absolutely. Small molecules induction, you don't have the antibody formation.
Ida, you've jumped the gun. Actually, that is one of the issues that we are going to be discussing subsequently. Can
I just make a quick comment? I think when we say that we induce remission with infliximab and then go to vedo, in principle, this may not be right, of course, because we always maintain the drug with which induction was achieved. In principle, when we induce remission, and in principle, the treatment options are that we should continue the same drug. To add on is a different policy. If we combine the two drugs right from beginning and continue, that's a different policy. But switching from one drug to another drug may not be a very safe policy.
So I get your point, because precisely that will be against the concept of principles of pharmacotherapy. Anyway, we move on.
This is what you're saying is a conventional wisdom. Agreed with that. But then when you have to look at the vastly developing field, you have to look at the new innovation and new strategies to look at that, looking at the both effectiveness as well as the safety and the cost, of course. That's it.
Okay. Ajay, over to you. You can start off this issue and then you could pick on your panel.
I think Mahmood wanted to say something, though. Is that
Mahmood?
right? Okay, maybe never.
Yeah, because I cannot see the screen, and because my so whoever wants to,
My quick question or comment is that it is really vedo is a slow drug, because as far as I know from the literature, I have no personal experience in Crohn's for vedo, but from literature, I think it can. I think this was the ad hoc analysis of the Gemini study that response can be as early as 2 weeks.
Okay, as early as 2 weeks. So that would make it quite a fast drug, isn't it?
So is it really a slower response?
Yeah. Okay.
Ramesh?
Yeah.
I just want to make a comment on my experience about vedolizumab in Crohn's disease. I will use it in two situations. One is that the patient does not respond to anti-TNF in those situations where my second choice between ustekinumab and vedolizumab, mostly because of financial reasons, now 1:1 is available. So I use vedolizumab. But I'll tell about the story of one patient who was on anti-TNF therapy, but she did not respond to the therapy. On follow-up, then I have started on vedolizumab. And at the end of 2 years, she has got almost complete mucosal healing. This is very unusual, but I'm telling you, vedolizumab can do very good in certain patients, and it is a good drug.
Okay, point well taken. We are onto the issue of biosimilars. Ajay, your comment on this, and then you could take on the discussion.
I think we had some discussion on the biosimilars, especially the Adali. Ajit did pass comments on that. And the question is, what is the future for that in a stricturing or a fistulizing Crohn's? Will we still be more comfortable with Adali? I mean, when you compare with the, say, infliximab or any other biosimilar coming up. Anybody wants to comment on that? Usha, what is your comments on that?
Sir, I think it is the cost which drives biosimilars. If the patient can afford the original molecule, I always prefer the original molecule. Only when we are faced with a situation where cost has implications, then we choose biosimilars.
Actually, if you go back to the slide which Simon showed in his registry, that's a very not a very encouraging one for the biosimilar point of view.
Yeah. Interesting, Ajay. I would consider conversation over. I think biosimilars, they work as well or as sustainable, and even switching between biosimilars doesn't seem to increase antibody trouble. And so we just use biosimilars throughout. It increases access for patients, and therefore the overall benefit to patients is increased because the threshold is low. I think, though, of course, in India, you've just got to remember that there are not only biosimilars, but there are biomimics, and which haven't gone through the same process of drug quality control. And this is only speculation, because you've had exemption for adalimumab in India for years now, and it's proved a good drug. So I would be the conversation about ustekinumab is very shortly going to come to a close, because ustekinumab is going to be available as a biosimilar when it comes off patent, and then that will be a great step forward. So I would regard biosimilars. I would use them out of choice, quite honestly, rather than the originator, as long as you're confident about the source.
I'm going to bring up something which about the Remsima Celtron biosimilar, because one of the things that Byung Dok Ye, a good friend of ours, said that it could be bio better because of the subcutaneous version. Because because of the Celtron Remsima biosimilar, you can actually get subcutaneous. You take subcutaneous once every 2 weeks after loading, and the trough levels are something to the level of 20. So I wondered what Simon thinks about that. Yeah. What's your opinion?
Yeah, no. There's a very fair point, Ida, and you do seem to get higher trough levels as a subcut. That's also true for Vido, because Vido subcut, I don't think yet available in India, but we use that frequently. And I think that the overall cost to the patient, if you're using subcut, is actually, because they don't have to go into an infusion center and come to hospitals is often left. So I think that if you believe drug levels are associated with better benefit, then there is a case for the subcut route. But measure the levels. That's the important thing.
Okay. So I think the important thing is, of course, that biosimilars are almost as good as the originators, but like Simon said, what is available in our country, more of them are biomimics, which have not gone through the rigorous tests, but that is something that we need to keep in mind. Adalimumab, Matthew Philip, you mentioned adalimumab, a preference in small bowel disease. I wonder why, but my question to you is, adalimumab, is it still good enough? You mentioned that you're going to use it in small bowel. But given all these developments which have happened over in the field of biologics, do you think that adalimumab is still good?
Adalimumab is actually a drug which I use keep it in the lowest thing, probably because of the but in my personal experience, I think infliximab is superior when I use patients for slicing Crohn's disease. But one situation which I have found useful, probably I have read an article, I don't remember that. In small bowel stricture in disease, ademab could be of some use. But there is not clear data on that, and I still don't. But I use adalimumab only when the patient says that I cannot afford other drugs. And this is convenience-wise, patient prefers that it can be self-administered. And he does not have to come to me frequently for infusion. In those situations, adalimumab. Otherwise, adalimumab is used as a drug which I keep it in the back only when only other drugs are not used for some reasons. Then only I use adalimumab.
Mahmood Omar, your opinion on this?
I don't use adenomumab. I don't use adenomumab again. Yeah, can you hear me?
At all. Okay, Professor
Yeah,
Simon.
Well, so I showed you the data on ulcerative colitis when I didn't know this question was going to come up. My rule of thumb for adalimumab is that if patients are over 100 kilograms in weight, they always need escalating dose to 40 milligrams every week. We still use it. It's a biosimilar. It's actually, and we sometimes start with it, but increasingly, because of the sustainability issue, we're starting with other agents and keeping anti-TNF therapy in the reserve.
Can I, Philip, GN, can I?
Yes, Ajit, carry on. Ajit, carry on.
Yeah, like if we go by literature, I mean, there are very few head-to-head trials between various biologics. The first head-to-head trial which came was Basti trial between adalimumab and Bido for UC. I mean, there is a trial, SEEV trial between Delhi and UST. And the results of SEEV trial clearly show that the efficacy between the two drugs is comparable. So Adali is not inferior to UST according to the SEEV trial. The response rate is same, and it's surprisingly very high with both the drugs. The only advantage of UST in the SEEV trial was the efficacy, the safety profile. Safety profile was a little better compared to Adali. Otherwise, the efficacy was the same. And I will agree with Matthew that because Exemptia has been available to us for a very long time, we have a maximum experience of using maximum experiences with Adali in Crohn's. And we find it fairly okay. The subcutaneous administration may not be a main advantage any longer because we are going to get soon infliximab subcutaneous, and Vido is already available as a subcutaneous preparation. But nothing has gone wrong with the Delhi. I will say it is a good drug, and it remains a good drug. And literature-wise, it's not inferior to UST. If we go by the main trials, we have to take the results of the trial.
I think GN got disconnected or something.
Is just joining back. He got disconnected.
Okay. Okay. Let me open up the slide presentation. Or you have the presentation, you can put it there.
Yeah, we can try that here.
Huh?
So I just wanted to ask one thing in the meantime, that we are discussing all this. If money was not a factor, would for majority of situations where there are no complications, just moderate to severe ulcerative colitis or Crohn's, should we prefer infliximab? Maximum experience, and I mean, I'm asking.
No, Rupa, I work in a system where money is not a constraint on therapeutic decisions. It's called the NHS, remarkable as that may be. It's the infliximab for acute severe colitis, but I, to be honest with you, the discussion previously about ustekinumab as first line for Crohn's, just focusing on Crohn's now. Well, you've got the head-to-head study of risankizumab versus ustekinumab, and guess what? Risa is better. That's the P19 inhibitor. So if money was no object, I would definitely go for risankizumab. And that's not yet available, I think, in India. But for Crohn's disease, then risankizumab I think. Scores closely followed, perhaps even bettered by upadacitinib as a small molecule JAK1 inhibitor. So upadacitinib, I think, is quite likely to be the future for Crohn's disease. I have no doubt that there are pharmacists working, even as we speak in India, to produce small molecule generic upadacitinib.
So I think since you have started this thing,
Yeah.
Dr.
That's
Ajay,
exactly the next question was this, what you have just preempted it. Will small
Sorry,
molecules,
but I
will small
apologize.
molecules play spoil sport to the biologicals? I mean, Ida talked about it earlier, and Simon opened up this subject.
wanted to-
I would like to take up this question.
Ida,
Yeah, I wanted to say that I have absolutely no doubt as well, like Simon, that the future is going to be the P19 drugs, the pure IL-23s. Out of curiosity, Simon, what about, I mean, I know the data is not out yet. What about musclekumab? What's your take on that, or mirikizumab? Do you think there's...
I like Miri. I mean, I think Miri for ulcerative colitis is good. The data for Crohn's disease will be presented at ECHO for Miri in Crohn's disease, and it works nicely, including Miri versus ustekinumab. And so I think the P19s are the right thing. But where you're losing response, the JAK1s, certainly upadacitinib, seem to have the edge, and that's very, very appealing indeed.
I think this the next question on the screen: will small molecules change the game? I think already we are seeing actually that for many patients we are giving tofacitinib in ulcerative colitis as first line, and the ECHO this year we're going to present the data. So we feel that it does work as a first line, though despite all the FDA approval and other side effects and other things, we haven't seen much in the patients that we have seen. So I think from the panel, we'd be looking for that. Oh, okay, Dr. Ajay is there. Yes.
Good.
Yes. No, Rupa, the main thing you mentioned that you have not seen much side effects, whatever they're being talked about. You were talking about in the relation with your experience with the TOFA and UC, or which drug you're talking about?
I'm talking of tofacitinib in ulcerative colitis.
Yeah. Do you think that these are different in our country because of the exposure to the infectious conditions before in the childhood?
It's a good
Side
question,
effect?
but we also have the herpes vaccine available now. We are seeing some mild lipid abnormalities, but nothing severe enough to stop the drug. We actually have submitted data of around about 200 patients given tofacitinib
Sorry about
first line. Yes, Ida.
Sorry.
Yeah.
It crashed. Yeah.
But all these patients are like, people who could not afford biologics. Biologics are always offered the first line.
So that's interesting, Rupa. I think that given the cost savings and the efficacy of TOFA in ulcerative colitis, absolutely, I would be arguing, and as I said in Bangalore, that using TOFA instead of azathioprine, to my mind, in ulcerative colitis wins hands down, safer, more effective, and fewer side effects. And the way I explain to patients about using TOFA in ulcerative colitis is simple. There is an increased risk of shingles. It's about 1 in 100 patient years of treatment. That means treating somebody for 10 years, you've got a 10% chance of acquiring shingles, and that can be prevented by the Shingrix vaccination. For DVT, if it applies to IBD, the risk is about 1 in 1,000 patient years. And of course, you need, but probably best avoided in people with previous history of DVT or other thromboembolic disease. But I think it's a very good drug, except that upadacitinib works in 8 out of 9 patients who have ulcerative colitis.
I think we need comments from the panelists on this, I think, from the ENT.
We are actually, this is basically the section on Crohn's disease, and my question is a very provocative one. That do we have any evidence to suggest that these small molecules would be useful in Crohn's disease?
Yes, Upada, that's easy. It's going to be launched.
It's going to be launched, but not yet available. But how strong is the data? And once it's available, do you think that it will move up the ladder to be one of the drugs of choice?
Certainly.
If I can extend the question further, if they are effective, will they be as effective in a complicated Crohn's as a...
Oh, I think more so, Ajay. I genuinely, having looked at the upadacitinib data in Crohn's disease, it's licensed and available here in the UK and from the States. I mean, the bizarre thing about the FDA is that they insist on having, before people go on a JAK inhibitor, they have to have lost response or not responded to an anti-TNF agent. Here we can use it first line, and I think UPA will change the conversation in Crohn's disease, just as tofacitinib has done in ulcerative colitis. So I think that it's a good drug.
That's a very
Can I ask?
The question is not actually provocative; it is closer to the reality. Huh?
Can I just ask Simon? Do you think that it's that upadacitinib is definitely much better than tofacitinib?
For ulcerative colitis, yes.
For both?
David, for probably for, tofa doesn't work for Crohn's disease.
For Crohn's, of course.
So look at the Chicago experience published in Clinical Gastrohep by David Rubin last year, and it very clearly UPA works where tofa people have not, with ulcerative colitis, not responded to ulcerative colitis. 2 randomized controlled trials in Crohn's disease shows tofa doesn't work in Crohn's.
Okay, that's interesting information, and so obviously we can close this issue here. The small molecules as available here in our country at the moment. No evidence to state that it's useful in Crohn's, but we'll have to wait for UPA to come. Okay.
I think,
Yeah.
get away with the impression that JAKis are not going to work for Crohn's. I mean, Simon has mentioned that UPA is going to change the scene. Upadacitinib and filgotinib. Filgotinib, phase 2 trials have been done. I mean, these are the 2 drugs, JAKis, which are likely to be effective. And filgotinib having some problem with the testicular toxicity, that may not be as popular as upadacitinib, but we see a lot of future for upadacitinib for Crohn's as well. And I think in developing countries, it's very, very pertinent. I mean, with TOFA, our use of biologics is definitely going to go down. And I want to share with you that with TOFA, what has happened with UC, that our use of steroids has tremendously gone down. So these small molecules, we are not discussing ozanimod. I'm sure that you might come to the ozanimod or etrasimod. I mean,
we will come to that.
Which have tremendous future in developing countries. I mean, keeping cost in mind.
Okay.
No, it's actually it's not.
So we have 2 different viewpoints. Actually, permit me to interject. Professor Simon says that we have 2 randomized controlled trials, which clearly says that tofa is not useful in Crohn's disease. We have Ajit Sood who says...
No. I'm not saying... No, please. I'm not saying tofa is useful in Crohn's. I'm saying upadacitinib is useful.
Okay.
Tofa is useful.
Okay.
There is a question that while we are on small molecules, Dr. Peshman from... Dr. Peshman Alavi Nazad, he just wants to know, how long do you continue the management with small molecules? Is there any long-term data available?
4-year data. There's 4-year data on sustainability, and it's and because there's no antibody formation, there does seem to be sustainable. The caveat, though, is that you shouldn't use JAK inhibitors or small molecule in pregnancy at this stage. There's been fetal toxicity, and therefore it advises against it. But then we've been using methotrexate and whatnot, and you just have to be conscious and you stop it a couple of months before patient plans to become pregnant. Funnily enough, it's been difficult to recruit men to the study of testicular toxicity and filgotinib. I don't think we'll ever get an answer to that. The trial, I think,
it's folded, right? I don't think they're going to launch it. I don't think they're going to launch filgotinib now, if I'm not mistaken, because I was part of the diversity study, and I think they unblinded everyone and then just said, we're probably not going to continue. So I don't think filgotinib is going to happen. So the other thing I wanted to ask, actually, which I find now that I'm using more small molecules, I looked at the data for, like, for example, upadacitinib, when you've got when you restart therapy after stopping. I found what disappointed me, at least, was that it didn't go back to 100%, Simon. Why is that? When we say that it's like a drug like paracetamol, it's a small molecule, right? If you have headache, a year later, then why would the effect not be identical? Why do you think
it's a very fair question, and of course we don't know and immunogenicity is only one component of response. I'm afraid, in a very non-scientific way, I consider it the rubber band effect. If you stretch a rubber band, it never goes quite back to the same conformation. But that ain't scientific; it's just an observation.
Okay, we now move on to. This is something that was referred to earlier about combo therapy issues and concerns. Do you think, Dr. Usha Datta, that combo therapy is something that is going to be a reality in the future? Combo therapy, I would say that, a combination of small molecules and biologics.
I think so, because both of them are acting at different components of the pathway. So ideally, better to go with a single drug. We don't have sufficient data on long-term efficacy of combo therapies, but in situations wherever they have been tried, they do seem to be more effective than a single therapy, and also it would minimize the side effects. So if cost is the issue, obviously combo therapy is of no use. Cost would dictate use of the small molecules alone. But otherwise, if we want more efficacy, then biologics with combo may have some edge over biologics alone.
I think Ida was the one who mentioned that theoretically you could think of JAK inhibitors because of the rapid onset of action to induce, and then you could go on to with the biologicals as a combination. Am I right?
Yeah, that's right. Because I think one of the concerns is exactly that. Because if you use infliximab, then of course, if you need it later on, you've developed antibodies to it all. But I guess if you give like tofacitinib and maybe upadacitinib and vedolizumab at the same time, and I'm thinking of a scenario, where would I do this? I was thinking maybe someone with a risk adverse, profile, somebody who's elderly, where you're going to be concerned eventually about the thromboembolic risk, or maybe the risk of shingles, even with Shingrix vaccine and all that, malignancy, of course. Although I don't know what the JAK signals for malignancy, I think it's really not very strong. Correct me if I'm wrong, Simon. So I think I just foresee a scenario where you might be if you put JAKs and maybe the IL-23s and the integrins, I guess the safety profile still favors the IL-23s and the anti-integrins, and maybe in those cases you might want to just start strong, with these drugs, and then later on, start, be it ustekinumab or vedolizumab, we can argue about that later, and then after that continue it later. That's how I foresee the combo of small molecule and biologics would be used. Yeah.
Thank you very much. Over to you, Ajay, for dealing with this section on ulcerative colitis.
Yes.
Jim, can I just make a comment as a flyer about that? Is that I think that combination therapy is going to work in IBD in the same way that it did with hepatitis C and other things. I think that's the direction to travel. But I want to flag up that the rheumatology experience is raised concerns about safety. But if you're going to echo, make sure you're there at presentation 1 on Thursday, because that'll blow your mind away about the management using biological treatment in Crohn's disease. And I'm not able to give you the results, but I think it's a game changer. And it all relates to the timing of starting biological therapy. But profile study is I think going to be a game changer.
Yeah, if I could just make a quick comment, there are two situations where combo therapy is useful. One, in patients with refractory disease. Second, the patients where besides IBD, there are extraintestinal manifestations. For example, a patient is on VIDO and patient has arthralgias. I mean, we can combine VIDO with, say, JAKis. So these are the two situations, refractory disease and EIMs. And when we talk of therapeutic ceiling with most of the biologics, and this is one option that if we use a combo, maybe we can not break the therapeutic ceiling totally, but we can raise the level to some extent.
See, look, I think we got a very short time left now, and we have to cover UC. We'll try to wrap it up and then just get some carry-home messages in the next 10 minutes. The only thing just I want to add to Ajit, just a thought, this thing, that combination therapy, the third situation, maybe, I'm not sure whether it's right, there is any evidence that by cutting down the dose of the each biologicals can be cut down the side effects of each. To consider that as a theoretical situation. Let's see, in ulcerative colitis, when we are discussing, we could, I think let's look at a clinical syndrome point of view. And the biggest challenge comes to us is, I mean, we have enough clear guidelines for the moderate to severe ulcerative colitis. But when it comes to acute severe ulcerative colitis, we know that what is the intensive regime, what is the first biologicals that we use. Question is, where do we fit small molecule here? Have we come to a situation where we can put in TOFA in this situation? Ajit, you recently published some data on that. What is your experience on this? Quick answers, clear this thing so that.
Yeah, I mean, TOFA was initially tried as a single drug for acute severe ulcerative colitis because the initial data showed that the response may come in 3 days or 2 days or even 3 to 4 days or so. But when we started using TOFA, that was not the case. So what we thought that we combine, we try to use it in patients where steroids don't work because the first drug remains injectable hydrocortisone and we still have around 1/3 of the patients who don't respond, and we have very limited options in the form of infliximab or cyclosporine in these patients or surgery. So we have found a combination by combining TOFA, we can cut down the non-refractory patients or steroid non-refractory patients to an extent. So we have found that if we combine TOFA with hydrocortisone, the steroid refractoriness decreases.
Simon, in your practice, will you go for still first choice as a biological?
So
are we reached a stage that we can think of using TOFA as well?
Yeah, I think TOFA 30 milligrams daily, there's been no randomized controlled trial, but the message is going high dose TOFA is useful rescue therapy in for acute severe colitis. We use it, but actually we also use cyclosporin and move on to VIDO. That's the sort of combo approach that Ida was highlighting. And we also use infliximab. But I think TOFA is a very good drug. And in where cost really matters, then I think TOFA in these circumstances is a good one. Ajit, I was interested by your data on suggesting that TOFA had to be used with steroids in acute severe colitis because the temptation has been to use TOFA just alone without, but I suspect it probably does need a boost with steroids.
I think so too, and actually it's very interesting because I've never used TOFA before. I've used Supada actually. I've used 30 milligrams BD based on which data was that? Also, again, a small case series with good results. In one case, the other one not so great. But I had somebody who came from India and brought 11 milligrams tofacitinib BD. I never heard of 11 milligrams. I'm not sure what that was about.
Yeah,
so
that formulation is available here now.
Okay, so
you said 30 twice a day. 30 twice a day, nobody is used. You said 30 billion.
Upadacitinib. Upadacitinib. Yeah,
Okay.
I've used upadacitinib for that. So the thing is, so what I did was, and then it came from Professor Sanjay, who's a friend of mine who doesn't really do much IBD, and what happened was I did up it to 33 milligrams. But I gave steroids at the same time. And I think the result was remarkable because from the CRP of 96, it went up to 128. I was chewing my nails a little bit. And then after that, it just went down to 56. And by day 5, it was already 10, the CRP. That's how acute, that's how fast it worked. And I think, I think I agree. I think from just my one experience, Professor Sood, it seems to be the correct combination.
Rupa, what is the current approval thing? I mean, is it fair to use TOFA for acute severe ulcerative colitis? Because is it approved for that from Indian context? Rupa?
No, I don't think it's approved for acute severe ulcerative colitis. But I think Dr. Sood has some experience from.
So the data is different, approval is different. So maybe we can
approval.
use it in the research setting, but not in a individual patient. But we can't recommend it to everybody.
In fact, there is
So
no
recommend
approval
to everybody.
in fact, there's no approval for tofacitinib as first-line therapy as well. So we
Yes,
have to
that's right.
offer patients biologics first, and when they say no or there is some strong contraindication, only then we can go to tofacitinib. But I suppose those things will change.
The next guidelines, when I think when we sit together for the
With our
guidelines, I
registry.
think we need. It's okay.
Then can we go to the next slide?
Yeah.
I think biologics discussion can all,
This one is okay.
We discussed that.
This one.
Okay.
So Ajit Sood was mentioning about the S1P modulators, etrasimod, ozanimod. My question is one more on the plate, but is it really good, or is it better than the options that are available now?
Yeah, I think it's available to us as a part of clinical trials only, but I think you have gone to etrasimod, bypassing ozanimod. I mean, there is more data with ozanimod rather than this etrasimod. This is the second line. But ozanimod again seems to be a very promising drug. If we do the proper titration and if we select our patients that cardiac toxicity is the main concern, and if we take care of our cardiac side effects, I think ozanimod or etrasimod both seem to be very safe drugs. With etrasimod, there's no need to have a titration. I mean, it can be started with the usual dose right from the beginning. So I think this is a very different group of drugs, and it's a very welcome drug, and its safety profile at the moment seems better than JAK.
Let's come, because we have lesser time. How far we are from getting approval for that?
Ozanimod is already approved for ulcerative colitis.
Okay, let me, sorry, different question. How far we are from getting it in India?
That I can't say.
You don't have any, Rupa has some information.
No information, but optimistic 1 year.
Okay. So
how expensive is it?
You use it in a regular
How expensive?
Quite.
Yes, Dr. Omar.
Yeah, how expensive compared to tofacitinib?
It's the cost of a biosimilar, Mohammed. And because we use it, I think ozanimod and indeed etrasimod will replace azathioprine. It's a very safe, stand fast, those people with 2-to-1 heart block or then you avoid it, but actually otherwise a very safe drug. I think it's a very good option for ulcerative colitis in place of ozanimod. But TOFA, it's a better side effect profile than TOFA, apart from the few people with a conduction defect.
But Simon, is it more effective? So you sort of said it would replace
we don't know.
azathioprine.
Well, I think it is as effective, comparing different to the True North study versus the TOFA trials. It is similarly effective, but they're comparing different trials.
Professor Simon, I just need you to be more specific. Now, you said it's going to replace azathioprine, which means that it's a good agent for maintaining remission. Am I right?
Yeah. Yeah,
Would it be a good agent for inducing
inducing,
remission?
yes, yeah. It works rapidly from the True North data, and it also is sustainable. The reason I sort of think it does have a future is that the JAK inhibitors do seem to have an adverse event profile. Okay, Zoster, we've discussed that, and others. But OZA, apart from its rather on-target effects on cardiac conduction, which only affect people with a pre-existent conduction defect. In other words, it's safe. Also, shouldn't be used in pregnancy, but I think it's a good drug.
Dr. Ajay, I think we need to bring this discussion to a close because we've run out of time. I've been told 7:30. We've had very intensive discussion based on personal experience and also based on evidence-based. Ajay, for your concluding remarks, and then we could hand it over to Dr. Gopal.
Oh, yes. No, I think you summed up that I think we had a good interactive discussion, very informal, and good sharing of minds. What is already approved, what is in the pipeline, and what is our practices, and looking at all different factors with a special focus on what is available in India and what is suitable for India. I think it has been for me personally, it has been a very great learning experience. And I hope Rupa will continue similar interactions in future. Over to you, Rupa.
Thank you. Thank you so much. I think I feel very elated that we took on a project, we got together so many meetings, and finally today we are able to say that the registry is ready. I do hope that all the key opinion leaders will start using it, and then we will have data to show. And this will be we'll all follow the same structured pattern. So the data is going to be authentic. Training sessions, as I said earlier, we will organize for every IBD physician who wants to join. And we are at that. We've had a wonderful discussion, and I think stalwarts like you have made us even forget about time, and we're running short. Thank you, Dr. Sood. Thank you, Usha. Thank you, Professor Travis. I can't thank you enough anyways. Professor Mahmood Omar, Dr. Ida, of course, happy birthday and thank you.
The birthday girl.
Dr. G.N. Ramesh has been my pillar of support for all the IBD master classes. Without him, it can't happen. And Dr. Ajay, thank you. Thank you for contributing. Dr. Matthew Phillip. And numerous IBD ENC members have joined, and you can see Dr. Peshman has already written, he's from Iran, that he will follow. We've got comments coming in from many places, not questions, but comments that we would like to join the registry. I'll bring this meeting to an end with we cannot thank enough our academic partner. Can I have the slide? We have an unrestricted grant from Pfizer for this registry and development of this platform. And our upcoming endeavors, I should highlight it as an endeavor, September 2024 with the AIG live program in Hyderabad, we will take stock of the problems and how much data we could collect and focus on specific projects that we can do based on the data, and at least one on practice patterns. November 2024, we plan a destination dedicated IBD ENC meeting, and you can watch out the space for more. Thank you. Thank you once again, and have a great week ahead. Ultimately, it's a teamwork, and I must thank the entire team here who have been going past the proformas, correcting which click will lead to which screen, and we've tried to make it as user-friendly as possible. The clinical team with Dr. Rajendra Patel, you met him, Dr. Shubhankar, Dr. Dhanush, and Dr. Nalini, and of course, the AIG technical team with Mr. Satyanarayana, Mr. Mohan, and Mr. Robin. So thank you once again.
Thank you.
Okay. Right.
Thank you, Rupa. Thank you.
Congratulations. Bye.
Thank you very much.
Thank you.
Bye. Professor Simon, thank you very much.